You know, there's a phrase I hear sometimes in the surgeon's lounge that honestly it drives me a little crazy. It's when a plastic surgeon refers to themselves as just the closer.
Oh, I hate that. It's the worst mindset you can have.
Right, like our entire job is to just walk in at the end, throw some sutures, and leave. But with breast cancer, I mean, if you operate with that mentality that you're just the technician, you're doing a massive disservice to the patient.
Absolutely. You can't build a house if you don't understand the foundation. And in breast reconstruction, the foundation is the oncology.
Exactly.
If you don't grasp the biology of why they're taking certain margins or why the oncologist is pushing for radiation, you just can't effectively plan the reconstruction. You're flying blind.
You are. So today on the deep dive, we are looking at breast cancer evaluation and treatment, but, strictly through the lens of the plastic surgeon. We are cutting through all the noise moving from risk assessment right into the OR.
Yeah, we need to look at how the pathology report actually dictates the procedure, the massive shift we've seen in surgical management, and the why behind those adjuvant therapies that, let's be honest, complicate our lives.
The mission today is simple. Upgrade your clinical decision-making. We want to move you from just closing the hole to being a true partner in the oncologic plan. So let's start with the landscape. It feels like everyone knows someone with breast cancer.
Because they probably do. It is the most common non-skin cancer in women, second leading cause of cancer death. But interestingly, the incidence has actually dropped a bit recently.
Which seems counterintuitive, right? With how much we screen, what drove that drop?
It's largely linked to women stopping hormone replacement therapy. That was a massive driver. Once that WHI data came out and HRT prescriptions just plummeted, the cancer rates followed. But the risk profile is still something you have to take a really detailed history on.
Right. And when we talk risk factors, aside from gender, what is the heavy hitter?
Age. Hands down.
Yeah.
We tend to focus on the young patients because they're tragic, they're memorable. But biologically, it's a probability game that just increases throughout life. Half of all cases are in women older than 65.
And then you have genetics. We all know BRCA.
We do. But you got to keep in mind, hereditary breast cancer is only about 5 to 10% of cases. It's a small slice, but it's a high-stakes one. BRCA mutations, especially in women of Ashkenazi ancestry, are the big ones.
So if you have that mutation, your risk is...
It's astronomical.
Yeah.
You're looking at a 60 to 85% lifetime risk for breast cancer.
And for the plastic surgeon, that history is what often triggers the prophylactic mastectomy conversation.
Exactly. That's where we come in before the cancer even exists. And don't forget the ovarian cancer risk, 10 to 40%.
Yeah.
That often dictates the timing of oophorectomy, which, well, it throws them into surgical menopause.
Which affects everything. Tissue quality, healing, all of it.
It's all connected.
One thing I feel gets glossed over in the history is reproductive history. We ask about it, but do we really understand the why?
It really comes down to one word: estrogen. I mean, it's all about the duration of exposure. Early menarche, late menopause, late first full-term pregnancy.
It's just more time, more menstrual cycle.
Precisely. It's that uninterrupted estrogen exposure that drives the cellular changes.
Okay, let's get to the part that really scares the residents, and honestly, some attendings, the PATH report. You get this report, it's a wall of text. It's so easy to just scan for positive margins and ignore the rest.
Which is a huge mistake. You have to simplify it. First, where is it coming from? Most cancers are ductal. That's the vast majority.
But the real confusion, and this is a classic board exam trap, is the difference between the precursors, DCIS versus LCIS.
Huge confusion point. And it changes your surgical plan entirely. Let's start with DCIS ductal carcinoma in situ. This is cancer. Full stop. But the key is, it is confined by the basement membrane. It hasn't invaded yet.
And because of screening mammography, we're seeing a ton of this, right?
About 30% of new cancers. And, not all DCIS is created equal. You have comedo and non-comedo. Comedo is the bad actor high-grade central necrosis. It's aggressive.
So the key takeaway for the surgeon is...
DCIS is a direct precursor. If you leave it, it has a high probability of becoming invasive. You have to clear it.
Okay. Now contrast that with LCIS lobular carcinoma in situ.
This is the clinical pearl for the episode. LCIS is generally not treated like a cancer that needs aggressive local clearance. LCIS is a marker of risk.
That's a nuanced distinction. What does marker of risk actually mean for the patient?
It means the patient has a 20% risk of developing cancer in either breast over the next 20 years. It's telling you the soil is bad, not just that one spot. So you don't necessarily need to do wide margins to clear it like you do with DCIS.
That completely changes the conversation. With DCIS, you're cutting to cure a specific lesion. With LCIS, you're managing a long-term probability.
Exactly. It's more about the surveillance strategy than the immediate surgical plan in a lot of cases.
What about those weird invasive variants? You see names on the report like tubular or mucinous. I think the instinct is to see a weird name and assume it's more aggressive.
But it's actually the opposite. When you see those specialized names, you should be relieved. Tubular carcinoma has an excellent prognosis. Mucinous is also favorable.
Even medullary carcinoma, which sounds scary and looks aggressive.
Right, it looks wild under the microscope, but it actually has a favorable prognosis. So don't panic when you see the variants.
Let's move to workup. Screen mammography starts at 40. That's the standard. But I want to talk about MRI. I feel like MRI is a double-edged sword in our field.
It absolutely is. Look, it's the most sensitive tool we have. We use it for high-risk patients, BRCA carriers, women who had chest radiation. It's also great for defining the extent of lobular carcinoma.
So what's the downside? Why not just MRI everyone?
Specificity. That's the friction point. MRI sees everything, including things that aren't cancer. It has a high false positive rate.
And I've seen this play out. You see something on MRI, the patient gets scared, the surgeon gets worried.
And suddenly, a patient who could have had breast conservation is getting a total mastectomy. We call it unnecessary mastectomy driven by anxiety. You have to be so careful not to overtreat based on MRI findings.
Speaking of confirmation, image-guided core biopsy is the standard, right? No one should be doing open surgical biopsies for diagnosis anymore.
No, that is just archaic. Core biopsy lets you plan your surgery based on a known diagnosis.
Okay, let's get into the OR surgical management. We have to address the history here because it dictates where we are today. We're still living in the shadow of the Halsted theory.
The radical mastectomy. Yeah. It's vital to understand what he was thinking. He believed cancer spread by permeating the lymphatics in this centrifugal way.
Like a stain spreading in a tablecloth.
Exactly. So logically, he thought if you just removed more tissue, the breast, the muscles, the nodes, you cured the patient.
And he was just wrong?
Fundamentally wrong. Biology rules survival. Cancer spreads via the bloodstream very early. That radical surgery offers no survival benefit over breast conservation plus radiation.
That was the NSABP B06 trial. That's the one everyone needs to know.
That's the landmark study. It compared total mastectomy versus lumpectomy alone versus lumpectomy plus radiation. Survival was the same across the board.
And there's a big but here. You can't just do the lumpectomy alone.
The radiation is key. If you do lumpectomy alone, the recurrence rate is nearly 40%. If you add radiation, it drops to 8%. So for breast conservation, radiation is non-negotiable for most patients.
And this is where the plastic surgeon's ear should perk up, because radiation changes everything for us.
It fibroses the breast envelope, it causes retraction, which brings us to APBI, accelerated partial breast irradiation. This is getting more popular and it has big implications for our work.
What's the thinking there?
Well, most recurrences happen right near the original tumor bed. So the thinking is, why radiate the whole breast if the risk is local? APBI uses catheters or a balloon to treat just that tumor bed.
And the timeline is way better for the patient.
Oh, much better. 1 to 2 weeks versus 6 to 7 weeks for whole breast radiation.
Yeah.
Plus, potentially better cosmetics because you aren't fibrosing the entire breast.
Let's talk about oncoplastic surgery. This is where our specialty really shines.
Yes, this is the bridge between the ablative surgeon and the reconstructive surgeon. It's combining tumor extirpation with plastic tissue rearrangement. It lets the oncologic surgeon take wider, safer margins without leaving a huge dent.
Who's the ideal candidate for this?
Patients with medial or inferior pole cancers are great. Or if you have to remove more than, say, 15% of that breast volume, if you just close that primarily, it's going to look deformed.
So you use glandular flaps, reduction mammoplasty techniques?
Exactly. You rearrange the breast tissue to fill the void. And often you'll do a reduction on the opposite breast for symmetry. It's a win-win. Better cancer op, better aesthetic outcome.
Anyone you shouldn't do this on.
Small breasts with a large tumor. It's basic geometry. If you have to take out a huge chunk of a small breast, there's nothing left to rearrange. Those patients are better served by a mastectomy and reconstruction.
Speaking of mastectomy, let's talk approaches. We've moved far away from the radical.
Thankfully, we standardly do skin-sparing mastectomies. You keep the inframammary fold, you keep the native skin envelope, it's oncologically safe, and it's the standard for immediate reconstruction.
And nipple-sparing mastectomy, that seems to be what every patient asks for now.
That is the next evolution, yeah.
Yeah.
You preserve the entire skin envelope, including the nipple areola complex. But you have to be really careful with selection.
Who can get that?
You want small to moderate breast size, minimal mitosis. You don't want a very droopy breast.
Why is that?
Blood supply. If the breast is very typtotic, the nipple is hanging so far away from the chest wall blood supply. If you core out all the tissue behind it, you risk necrosis of the nipple.
And if there's a local recurrence after these procedures?
Usually that means a total mastectomy. But the rates are quite low in well-selected patients.
Let's move to the axilla. This is another area where less is more has become the mantra.
Yeah, and it's saving our patients a lot of misery. Management of the axilla is for staging and regional control. But your clinical exam is terrible. Up to a quarter of normal-feeling axillae actually have micromets.
So we used to do full axillary lymph node dissections on everyone.
And we caused a lot of lymphedema, arm stiffness, pain. It was morbid. Now, the standard is sentinel lymph node dissection.
The Veronese trial was the game changer here.
It was. Veronese randomized patients to SLND plus axillary dissection versus SLND alone. No difference in disease-free survival, but the SLND alone group had way better arm mobility and less pain.
So if the sentinel node is negative, you stop. You spare the patient all that morbidity.
Correct.
But here is the shift that's really interesting and frankly a bit controversial still. What if the sentinel node is positive?
This is the new frontier. I mean, emerging data suggests that in early breast cancer treated with excision and whole breast radiation, you can actually omit the completion ALND, even if that sentinel node is positive.
That is huge. 10 years ago, that would have been malpractice.
It would have been. But we're realizing that the radiation and systemic therapy, they clean up the microscopic disease in the remaining nodes. It's another nail in the coffin of the Halsted theory.
Which is the perfect segue to those adjuvant therapies, the safety net.
Right. Surgery is local control. Adjuvant therapy treats the systemic risk.
Let's look at how this applies to DCIS first. How do we decide how aggressive to be?
Well, we can use the Van Nuys prognostic index. It looks at grade, size, and necrosis to predict recurrence. And margins always matter. For many, we add radiation. The NSABP B17 trial showed radiation reduces local recurrence in DCIS from 16% down to 7%.
What about tamoxifen for DCIS?
The NSABP B24 trial looked at that. Tamoxifen reduces the risk of ipsilateral breast tumors and, crucially, contralateral events.
Okay, now let's talk about the elephant in the room for us. Post-mastectomy radiotherapy. PMRT. Radiation and implants are not best friends.
They are enemies, frankly. Capsular contracture, infection, extrusion. The rates of all of these just skyrocket with radiation. But sometimes you have to do it.
What are the hard indications where we just have to deal with the radiation risk?
4 or more positive nodes, large tumors, or close surgical margins.
And the benefit is that substantial.
It reduces locoregional recurrence by about 67%. That is a massive number. And in node-positive patients, it translates to a survival benefit.
So we can't argue with the survival benefit, but there is a trade-off.
There is. While you reduce cancer death, you can see an increase in cardiac mortality from the radiation toxicity to the heart, especially with left-sided cancers.
Finally, systemic therapy. Chemo and hormones.
This is all aimed at occult metastases. We have neoadjuvant chemo giving it before surgery. This is becoming really common.
And this is great for us, right?
It is. You can shrink a tumor enough to allow for breast conservation instead of mastectomy. The response rates can be pretty impressive.
And hormonal therapy, that depends on menopausal status. Can you clarify the difference?
Sure. Tamoxifen is a SERM. It blocks the estrogen receptor. It's the go-to for premenopausal women. But for postmenopausal women, we use aromatase inhibitors.
Because they block the production of estrogen itself.
Exactly. In postmenopausal women, estrogen is made in peripheral fat. Aromatase inhibitors block that conversion. And they've been shown to be more effective than tamoxifen in that group.
So to wrap this up, we've covered a lot of ground. If you're a plastic surgeon listening, what are the big takeaways?
First, Halsted is history. We cure by understanding biology and using multimodal therapy, not by cutting out more tissue.
Second,
Understand the pathology. LCIS is a risk marker. DCIS is a precursor that needs local control. Don't confuse them.
and third,
The axilla. We are doing less. Sentinel node is standard. And even with positive nodes, we are moving away from full dissections.
and finally, oncoplastics.
It's the future. You can get wider margins and better aesthetics. It's just, you have to know your patient selection.
It really comes down to this. As reconstructive surgeons, we are part of the cancer team. Understanding why they're doing a lumpectomy versus a mastectomy, or why the oncologist is recommending radiation, that directly impacts how we reconstruct that breast.
Precisely. You can't just be a technician, you have to be a clinician. Your knowledge of the biology is just as important as your suture technique.
That is the bottom line. Thanks for diving in with us.
My pleasure.
And for those listening, here's a final thought. We talked about how MRI can lead to overtreatment. Ask yourself this. In an era where we are de-escalating surgery for the axilla and relying more on systemic therapy, are we approaching a time where the perfect imaging diagnosis matters less than the biologic profile of the tumor? It's something to think about. Catch you on the next deep dive.